Welcome to the deep dive. Today we're tackling something really crucial for pet owners: dyspnea, or difficulty breathing, and respiratory distress in our dogs and cats.
That's right.
We've got some, pretty detailed medical information here, and our goal is to make sense of it, what these terms actually mean, the red flags you should watch for, what might be causing the trouble,
Mhm.
and how vets go about figuring it all out and treating it.
Exactly. It's really about giving you a clearer picture of what's happening if your pet is struggling to breathe. Because, well, catching those early warning signs can really make a huge difference.
Hmm.
We're going to take this potentially overwhelming information and, break it down into practical takeaways for you.
Okay, sounds good. Let's start with the basics then. What is dyspnea exactly? Now, the initial definition here, it's from a human standpoint, an uncomfortable sensation in breathing, that feeling of being like air hungry.
Hmm.
How does that translate to what we might see in our pets?
Well, since our dogs and cats can't just tell us they're feeling breathless, right? In veterinary medicine, dyspnea is what we observe as difficulty breathing or respiratory distress. It's the outward sign that they're likely experiencing that uncomfortable sensation.
Okay.
Think of it as their body's way of saying, hey, I'm not getting enough air here.
And what's the underlying issue when an animal is experiencing this? What's actually going on inside their body?
So what's fascinating here is that it's believed to be a bit like a miscommunication within their control center for breathing. That's the central nervous
A
system.
miscommunication?
Yeah, the idea is that the brain tells the body how much to breathe. That's the ventilation band. Then it gets feedback on how well that breathing is actually happening.
Hmm.
If there's a mismatch between what the brain expects and the feedback it's getting, that's when we see dyspnea and respiratory distress.
Hmm.
So it's not always just about a problem in the lungs themselves.
Huh. So it's like the brain's not getting the right confirmation that breathing is working properly. That's a really interesting way to put it. Now, which part of the body are we primarily talking about here? And is this something that affects all sorts of animals?
The main system involved is definitely the respiratory system, so the airways in the lungs.
Okay.
And while breathing difficulties can occur in many species, our focus today, based on this information we have, is specifically on dogs and cats.
Got it.
It's also worth noting, though, that things like age, breed, even sex can make certain animals more prone to specific causes of dyspnea.
Right. Certain breeds are more susceptible. Okay. So our mission for this deep dive is to get a good grasp on the basics, the key signs to look for, the potential causes, and how vets approach diagnosing and treating breathing difficulties in dogs and cats. Let's jump into those signs. What are some of the historical things an owner might notice at home, maybe before they even get to the vet?
Yeah, often owners will report that their pet's breathing problems seem to come on. Suddenly, that's what we call acute onset.
Oh,
Or maybe they've developed more gradually over time, which we'd call chronic.
right.
They might also mention their pet coughing more than usual or breathing really rapidly. The medical term for that is tachypnea,
Dyspnea. Okay.
or becoming easily tired during exercise, showing what we call exercise intolerance. They just can't keep up like they used to.
And when a vet is actually examining a pet who's having trouble breathing, what are some of the sort of general physical signs they'll be looking for?
Well, there are several pretty telltale signs. You might see them using their abdominal muscles more to help them breathe. You might notice their belly moving in and out more forcefully than usual.
Okay, like really working at it.
Exactly. Nasal flaring, where their nostrils widen with each breath, that's another common indicator. Open mouth breathing in a cat, especially if they're not hot or obviously stressed, that's always a major red flag.
Right. Cats usually breathe through their noses.
They do. We might also see cyanosis, which is that bluish color to their gums or tongue. That tells us they're not getting enough oxygen.
That sounds serious.
It is. And then there's orthopnea. That's where they adopt a specific posture to try and breathe easier. Often they'll stretch their neck out and keep their elbows kind of wide apart, trying to open up the chest.
Those are some pretty clear things an owner could potentially spot then. Now, the information here goes into more specific physical exam findings, depending on where the problem might be located in the respiratory system. Let's start at the top, with the nose. What might a vet notice there?
Right, so with nasal issues, you might actually hear stertor. That's a noisy kind of snorting sound when they breathe.
Stertor. Okay.
There could be discharge coming from their nose, obviously. And you might feel that there's less airflow coming through one or both nostrils when you check.
Hmm.
Interestingly, if the problem is only in the nose, their breathing might actually seem to improve when they open their mouth because they're basically bypassing that nasal blockage.
Ah, that makes sense, like taking a detour for the air. What about problems a bit further back in the upper airway, sort of behind the nose and mouth?
In upper airway disease, you're more likely to hear stridor. That's a high-pitched, almost whistling sound, and it's usually loudest when they inhale.
Stridor, okay. Different from stridor.
Exactly. Coughing, maybe a high body temperature hyperthermia,
Yeah.
and you'll often see increased effort when they're breathing in.
And tracheal collapse. I know that's something we hear about, especially in like smaller dogs.
Yeah.
What are the typical signs for that one?
Yeah, the classic sign of tracheal collapse is a very distinct honking cough. It almost sounds like a goose honk.
Right, I've heard that described before.
Your vet might also find that the trachea, the windpipe, is sensitive when they gently feel it in the neck area.
Okay. Moving down into the lower airways now, the smaller tubes inside the lungs. What might be heard when a vet listens to their chest with a stethoscope?
With lower airway disease, a cough is pretty common. And when listening what we call auscultation, your vet might hear wheezing sounds. These are often most obvious when the animal is breathing out.
Wheezes on the exhale.
Got it. And what if the issue is in the lung tissue itself?
Yeah.
The parenchyma, the part where the actual oxygen exchange happens.
This can be a bit more tricky, actually. When listening to the lungs, sometimes you might hear crackles or sounds that seem harsh or maybe moist.
Okay.
However, surprisingly, in some cases of lung tissue disease, the lungs might actually sound relatively normal on auscultation.
Really? That just highlights how complex this can be, doesn't it? Trying to pinpoint the problem. What about pneumonia, specifically an infection in the lungs? Are there specific signs linked to that?
Yes, with pneumonia, a fever is often present, and similar to tracheal collapse sometimes, the trachea might be sensitive to the touch when examined.
The text also mentions cardiogenic pulmonary edema that's fluid in the lungs because of heart problems, right?
Right.
How might that present differently?
Right. So if the heart is the underlying issue, your vet might hear a heart murmur or an irregular heartbeat, which we call an arrhythmia.
Other signs can include a lower than normal body temperature hypothermia, maybe pale gums, and a slow capillary refill time. That's how long it takes for the pink color to return to the gums after you press on them briefly.
Okay, so clues pointing towards the heart. And what if the problem is in the pleural space? That's the area between the lungs and the chest wall.
Pleural space disease often leads to reduced or muffled breath sounds when listening with a stethoscope.
Okay.
And where those sounds are reduced can give us clues. If it's lower down towards the belly, that might suggest fluid. If it's higher up towards the back, that could indicate air trapped there in pneumothorax.
Ah,
If it's only quiet on one side, it might point towards a mass or maybe a collection of fluid or pus just in that specific area. A key sign here can also be paradoxical breathing.
paradoxical breathing. What's that?
That's where the abdomen actually moves inward when the animal tries to inhale, which is the opposite of what you'd normally expect to see. The chest and belly aren't moving together correctly.
Wow, okay. That's a really important distinction to note. What about if the problem lies in the chest wall itself, like the ribs and muscles?
Thoracic wall disease can also present with that paradoxical breathing sometimes. You might also see or, feel signs of trauma like broken ribs or instability.
Makes sense. Finally, the information mentions pulmonary thromboembolism, or PTE. That's a blood clot in the lungs. What might be observed in those cases? It sounds tricky.
PTE can be quite challenging to diagnose, you're right. The signs can be really varied. Sometimes you might see signs related to an underlying condition that makes blood clots more likely.
Like what?
Oh, things like Cushing's disease, that's hyperadrenocorticism, or a type of anemia where the body attacks its own red blood cells, called IMHA, or even certain types of cancer.
Okay.
Other signs might be more general, like the animal presenting in shock or showing evidence of recent injury or surgery. It's often a diagnosis we arrive at after ruling other things out.
So a really broad spectrum of potential signs, depending on where the problem is located and what's actually causing it. Let's move on to those causes and risk factors then. The text organizes these by the location of the issue, which seems helpful. Let's start back at the top with the upper airway. What are some specific examples of what can go wrong there?
Okay, upper airway. Starting right at the front, the nose,
Yeah.
we can see blockages caused by things like stenotic nares. Those are the narrowed nostrils we often see in brachycephalic breeds, the flat-faced dogs and cats.
Right, like pugs or Persians.
Exactly. Other possibilities include growths called nasopharyngeal polyps or a narrowing called stenosis, infections, inflammation, tumors, neoplasia trauma, foreign objects getting stuck up there, and even problems with blood clotting, coagulopathies.
Okay. Moving back just a bit to the pharynx, that area at the very back of the throat, what can cause problems there?
Common issues in the pharynx include an elongated soft palate again, often seen in those brachycephalic breeds. Foreign objects can get lodged back there too. Tumors and inflammatory masses called granulomas can also obstruct the pharynx.
And the larynx, the voice box area, what can lead to breathing difficulties originating there?
The larynx is actually a pretty frequent site of problems causing dyspnea. We see laryngeal paralysis, especially in older, larger breed dogs.
Hmm.
Everted laryngeal saccules. Those are small pouches of tissue near the vocal cords that can get sucked into the airway. Swelling or edema, collapse of the larynx structure itself, foreign bodies, tumors, trauma, and even abnormal tissue connections called webbing can all cause obstruction.
Lots of possibilities there. Finally, for the upper airway, we have the trachea, the windpipe. What are some common causes of tracheal issues?
Well, tracheal collapse is a significant one, as we've already mentioned, especially in small breeds.
That honking cough.
That's the one. Other causes include a narrowing of the trachea, called stenosis, injury, foreign objects again, tumors, even certain parasites in some regions. And importantly, the trachea can also be squeezed or compressed from the outside
Oh, right. By what?
by things like enlarged lymph nodes nearby, an enlarged left atrium of the heart pushing on it, or certain tumors that grow at the base of the heart.
So, a lot of potential obstructions or malfunctions just in that upper airway tract. What about the lower airway? Those smaller tubes, the bronchi within the lungs? What are the common causes of breathing problems starting there?
Down in the lower airways, we tend to see more inflammatory conditions, infections. Mycoplasma is one specific type mentioned. Parasitic infections like lungworm can affect the lower airways. And again, tumors, specifically a type of lung cancer called bronchogenic carcinoma, can originate there.
Okay, now let's delve into the pulmonary parenchyma, the actual lung tissue itself, where the gas exchange happens. This seems like the core working part of the lungs. What can go wrong right in there?
Yeah, a major category here is edema, which is fluid buildup within the lung tissue. This can be cardiogenic, meaning it's related to heart failure.
Right, the heart isn't pumping efficiently.
Exactly. Or it can be non-cardiogenic, meaning it's caused by something else entirely, like severe inflammation or injury. Pneumonia, inflammation of the lungs is another big one.
And that can have different causes too, right?
Absolutely. It can be caused by infections, bacterial, viral, fungal, parasites, accidentally inhaling things like food or vomit, that's aspiration pneumonia. There's also eosinophilic pneumonia, related to certain white blood cells, often allergic, or interstitial pneumonia, affecting the tissue between the air sacs.
Right.
Tumors are also significant here, both primary ones originating in the lung and metastatic ones that have spread from cancer elsewhere in the body. We also see inflammatory conditions like acute respiratory distress syndrome, or ARDS, which is a very severe generalized lung inflammation, uremic pneumonitis, which is lung inflammation related to severe kidney failure, and of course damage from smoke inhalation.
Wow.
Bleeding into the lungs, called pulmonary hemorrhage, often from trauma or blood clotting problems, can lead to dyspnea. And we need to consider pulmonary thromboembolism, PTE, again, those blood clots lodging in the lung vessels.
What you said can be linked to other conditions.
That's right. Often linked to IMHA, protein loss through the kidneys, PLN, or intestines, PLE, heartworm disease, Cushing's disease, and various tumors. Finally, other, perhaps less common causes include lung lobe torsion, where a section of the lung actually twists on itself, cutting off blood supply,
Ouch.
and atelectasis, which is basically collapsed lung tissue.
That's a really comprehensive list of potential issues just within the lungs themselves. What about that pleural space again, the area surrounding the lungs?
Right, the pleural space. We can see pneumothorax, which is air trapped in that space, collapsing the lung.
And that can happen in different ways.
Yes. It can be traumatic, like from a bite wound or being hit by a car. Iatrogenic, meaning caused by a medical procedure like a chest tap gone wrong. Secondary to underlying lung disease like a ruptured air sac or bulla. From a foreign object that is migrated into the chest, or even sometimes it's primary spontaneous, meaning it happens for no obvious reason.
Spontaneous pneumothorax, huh?
Yeah. Then there's pleural effusion, which is fluid buildup in that chest cavity. And the type of fluid matters.
Okay.
It could be transudates, which are typically clear, watery fluids from pressure imbalances, like with low protein or heart failure. Exudates are inflammatory fluids, often cloudy, seen with infection or inflammation, like pyothorax, which is pus. Chemothorax is blood, usually from trauma or clotting issues. And chylothorax is lymphatic fluid, which looks milky.
So analyzing the fluid is key.
Definitely. We also have to consider soft tissue problems in the pleural space, like tumors growing there, or diaphragmatic hernias, where organs from the abdomen push through the diaphragm into the chest cavity. Lastly, scarring of the lining of the chest cavity, called fibrosing pleuritis, can restrict how well the lungs can expand.
Okay. And what about the chest wall itself? Can problems there lead directly to breathing difficulties?
Absolutely. An open chest wound, an open pneumothorax, often from trauma, is an emergency. And flail chest, where you have multiple rib fractures causing a segment of the chest wall to move paradoxically inward when breathing in, that severely compromises breathing.
Right. The mechanics are all wrong.
Exactly. Tumors in the chest wall can also interfere. And then there's paralysis of the muscles involved in breathing.
Paralysis from what?
It can be caused by various things. Problems high up in the neck affecting the spinal cord, cervical spinal disease, certain toxins like botulism, inflammation of multiple nerve roots, polyradiculoneuritis, tick paralysis from certain tick species, a neuromuscular junction disorder called myasthenia gravis, or even venom from certain snakes like elapids.
Wow, quite a range. We've also got diaphragmatic disease listed here as a potential cause. What can go wrong with the diaphragm, that big muscle separating the chest and abdomen?
Injury is a big one for the diaphragm. It can rupture, causing a tear, or lead to a hernia, where abdominal contents can move up into the chest through an opening.
Okay.
Diseases affecting the phrenic nerve, which is the nerve that controls the diaphragm, can cause paralysis or weakness. Tumors involving the diaphragm and scarring or fibrosis of the diaphragm itself are also possibilities that can limit its movement.
Okay. And finally, the information mentions abdominal distension, basically. A really swollen belly as a cause of dyspnea. How can that affect breathing? Seems indirect.
It does, but a significantly swollen abdomen really pushes up on the diaphragm from below. This limits how much the diaphragm can move downwards when the animal tries to inhale, and therefore restricts how much the lungs can expand.
Ah, I see. Less room for the lungs. What causes that kind of distension?
It can be caused by enlarged abdominal organs, organomegaly, due to things like tissue overgrowth, hyperplasia, tumors, or even pregnancy. Simple obesity can contribute significantly too. Fluid buildup in the abdomen, called ascites, is another common cause, and a condition called gastric dilatation and volvulus, GDV or bloat, where the stomach fills rapidly with gas and often twists, causes massive abdominal distension and severe breathing difficulty. That's a critical emergency.
Absolutely. Okay, that's a really extensive overview of the potential causes. It truly highlights how many different things can impact breathing, doesn't it?
It really does.
So when a vet is faced with a pet who's clearly struggling to breathe, how do they even begin to sort through all these possibilities? Let's talk about diagnosis. How do they put these pieces together?
Yeah, it's a process. The first step is often trying to narrow down the possibilities based on the pattern of breathing, like we touched on with the signs.
Right, inhale versus exhale.
Exactly. If they're having more trouble breathing in inspiratory dyspnea, that often suggests a problem in the upper airway, basically outside the chest cavity.
Okay.
If they're struggling more to breathe out expiratory dyspnea, that often points towards issues in the airways within the chest, the lower airways.
Makes sense.
However, if they're having significant trouble with both inhaling and exhaling, that can happen with fixed blockages in the upper airway that don't change with breathing, or it can indicate pretty severe disease inside the chest, like widespread lung disease or pleural space problems.
Gotcha.
It's also really important right at the start to try and differentiate true respiratory distress from conditions like congestive heart failure, which can sometimes look very similar.
What are the clues for heart failure?
You might find things like a heart murmur, an irregular heartbeat or arrhythmia, a really fast heart rate, tachycardia, maybe weak pulses, seeing pulsations in the jugular veins in the neck, sometimes a low body temperature, hearing crackling sounds in the lungs, and occasionally even fluid discharge from the nose. Those things might steer you more towards a cardiac cause.
So the physical exam gives really important initial clues, but what about laboratory tests? What information can blood work, urine tests, and other lab analyses provide?
Oh, they provide a ton of information. Basic blood tests, like a complete blood count, CBC, and biochemistry profile, plus a urinalysis, can give us valuable insights into what's happening systemically.
How so?
Well, for example, severe anemia, a really low red blood cell count on the CBC, might sometimes cause breathing difficulties just because there aren't enough cells to carry oxygen effectively, even if the lungs are okay.
Non-respiratory dyspnea, right.
Exactly. On the flip side, a high red blood cell count, polycythemia, can suggest the body has been trying to compensate for chronic low oxygen levels over a longer period. An elevated white blood cell count, what we call an inflammatory leukogram, could point towards an infection like pneumonia, or maybe pus in the chest, pyothorax.
Okay.
Finding a high number of a specific type of white blood cell called eosinophilia might suggest an allergic airway disease, or perhaps parasitic infections in the airways.
Interesting.
A high platelet count, thrombocytosis, has been linked, particularly in dogs with Cushing's disease, to an increased risk of those blood clots in the lungs, PTE.
Right.
Looking at the biochemistry, an abnormal ratio of sodium to potassium can sometimes be seen with fluid buildup in the chest or abdomen, especially with certain causes like Addison's disease or ruptured bladder.
Okay.
High levels of waste products in the blood. Azotemia, if it's really severe, can actually contribute to lung inflammation due to kidney failure, that uremic pneumonitis we mentioned. Finding protein in the urine, proteinuria, especially in large amounts, can indicate kidney disease that might also increase the risk of blood clots, again, PTE.
It's all connected.
It often is. Signs of multiple organ problems on the blood work might raise suspicion for ARDS. And finally, low protein levels in the blood, hypoproteinemia, can be a sign of diseases that cause protein loss, like PLN or PLE, which again can increase the risk of PTE, or sometimes lead to fluid buildup in the chest, hydrothorax, due to low oncotic pressure.
Wow, that's a lot of information you can potentially get just from those initial basic lab tests.
Yeah.
What about some of the other, maybe more specific laboratory analyses mentioned in the text?
Right, beyond the basics, if there's fluid in the chest that we can sample, analyzing that fluid, pleural fluid analysis is absolutely crucial. It helps us figure out if it's infection, blood, chyle, or something else.
Okay.
Examining a stool sample, a fecal exam, might seem unrelated, but it can help us identify lungworm or other parasites that could be causing respiratory signs.
Good point.
Specific blood tests can look for infectious agents like heartworm antigen or antibodies to things like toxoplasmosis, distemper virus, FOV or FIV, depending on the species, and clinical picture. If we see significant protein in the urine, measuring the urine protein, creatinine ratio helps quantify it. A very high ratio in protein-losing nephropathy suggests loss of antithrombin, a natural blood thinner, which significantly increases the risk for PTE.
Okay, that makes sense. What about blood gases? You mentioned those earlier.
Yes, arterial blood gas analysis is a really powerful tool. It directly measures the level of oxygen dissolved in arterial blood, the PO2, and the level of carbon dioxide, the P-2. It also tells us the percentage of oxygen the animal is breathing, the FiO2.
And what do those numbers tell you?
Well, the PO2 tells us how well the lungs are oxygenating the blood. Normal on room air is usually somewhere between 80 and 120 millimillimeters G. A low PO2, hypoxemia, indicates the animal isn't getting enough oxygen into their system.
Right.
The ratio of PO2 to the FiO2 is a key indicator of lung efficiency. A ratio above 500 is generally considered normal. Lower ratios suggest progressively more severe lung dysfunction.
Okay, and the CO2?
The PACO2 reflects how well the animal is ventilating, breathing out carbon dioxide. Normal is typically around 30 to 40 millimilli Hg. High PACO2 hypercapnia suggests they aren't breathing deeply or frequently enough to clear CO2, maybe due to airway obstruction, muscle fatigue, or neurological issues.
Got it.
If getting an arterial sample is difficult or risky, sometimes we'll use a venous blood gas, PVCO2, which gives a rough idea of ventilation, though not oxygenation. If we suspect bleeding is contributing, we'll often run blood clotting tests, coagulation testing. And finally, there are some specific blood markers, things like NT-proAMP, BNP, ET1, and cardiac troponin I, CPNI, that can sometimes help differentiate between heart-related causes of dyspnea and non-heart causes, although they need careful interpretation.
So blood gases really give you direct measure of how well the lungs are actually performing their job. What about imaging techniques? What role do things like X-rays and ultrasounds play in figuring out the cause of dyspnea?
Imaging is often absolutely essential. Chest X-rays or radiographs are usually one of the first steps and can reveal a huge amount.
What kind of things can you see?
Well, in upper airway disease, they might show indirect signs like a long, soft palate, maybe a narrowed airway, enlarged lymph nodes compressing the trachea, or sometimes even a visible foreign object. For lower airway disease, you might see thickened airway walls like donuts or tram lines, sometimes collapsed lung lobes, especially in cats, maybe signs of air trapping like overinflated lungs or a flattened diaphragm.
Okay.
With pneumonia, you often see characteristic patchy or consolidated opacities in the lung fields. Heart-related fluid in the lungs, cardiogenic edema, typically shows an enlarged heart silhouette, prominent pulmonary blood vessels, and specific patterns of fluid buildup, although it can look a bit different in cats sometimes, more patchy.
Okay.
Fluid buildup from other causes, non-cardiogenic edema, often has a different distribution pattern on the X-rays. ARDS often shows very severe, widespread, fairly symmetrical, fluffy opacities throughout the lungs. X-rays can also help identify problems with the pulmonary blood vessels, like enlargement seen with blood clots or heartworm disease. And they're crucial for spotting issues in the pleural space like free air, pneumothorax, or fluid pleural effusion, identifying masses, or seeing a tear in the diaphragm with abdominal organs in the chest.
Mm-hmm.
They can also show problems with the chest wall itself, like broken ribs or tumors arising from the ribs or surrounding tissues.
So X-rays are really a cornerstone. What about ultrasound?
Ultrasound of the chest, sometimes called TFAST or VET-BLEU, is particularly useful for evaluating pleural effusion, confirming its presence, estimating volume, and guiding sampling. It's also very sensitive for detecting pneumothorax by looking for the absence of a normal glide sign between the lung and chest wall.
Ah, interesting.
And it can assess the lung surface for signs of fluid or inflammation, like beelines or comet tails, and help identify lung masses that are close to the surface. It's also good for looking at the mediastinum, the area between the lungs.
Okay.
An ultrasound of the heart, an echocardiogram, is critical if we suspect heart disease as the cause or a contributing factor.
Hmm.
It lets us assess heart chamber size, wall thickness, and how well the heart is contracting. Signs like high pressure in the pulmonary artery or enlargement of the right side of the heart can support a diagnosis of PTE. Echo can also help visualize heart-based masses that might be compressing airways.
Right.
We might also use X-rays or ultrasound of the abdomen if we suspect abdominal distension is contributing to the breathing problem.
What about things like fluoroscopy or CT?
Fluoroscopy, which is like a moving X-ray, is really good for evaluating dynamic conditions like tracheal collapse or bronchial collapse, as you can watch the airway narrow during breathing. You can also assess diaphragm movement. A CT scan provides much more detailed cross-sectional images of the airways, the lungs, and the pleural space. It's excellent for detecting subtle lesions, like small tumors, bullae, or early pneumonia that might not be clear on regular X-rays. It's particularly good for evaluating pulmonary thromboembolism as well.
Okay.
Pulmonary vascular angiography, where dye is injected into the blood vessels of the lungs during imaging, is considered the gold standard for definitively diagnosing PTE, but it's more invasive. And finally, a nuclear medicine scan called ventilation perfusion scintigraphy can show areas of the lung that are getting air but not blood flow, which is suggestive of PTE, but it's not widely available.
That's an impressive range of imaging tools available to vets now. And finally, what about more direct diagnostic procedures? Things you do to the patient.
Right. Pulse oximetry, using that little clip on the tongue or lip, gives us a non-invasive estimate of the oxygen saturation in the blood, the SpO2. It's a useful, quick check and for monitoring trends.
But it has limitations.
Yes, it's important to know that it doesn't always perfectly reflect the actual oxygen level in the arteries, PO2, especially when the animal is breathing supplemental oxygen, as the saturation can stay high even if the PO2 is dropping. It can also be affected by poor perfusion, pigmentation, or movement.
Okay.
A chest tap, thoracocentesis, is essential if there's significant fluid or air in the pleural space. It's both diagnostic, allowing us to analyze the fluid or confirm pneumothorax, and often therapeutic, relieving pressure on the lungs. The fluid should ideally be sent for analysis and culture. Laryngoscopy, nasopharyngoscopy, and tracheoscopy involve using a small camera, an endoscope, to directly look at the larynx, nasal passages, pharynx, and trachea. This is great for finding things like foreign objects, masses, polyps, or signs of paralysis or collapse.
So you can see the problem directly.
Exactly. Bronchoscopy uses a longer, flexible scope to go even further down, allowing visualization of the larger bronchi within the lungs. A key procedure often done during bronchoscopy is bronchoalveolar lavage, or BAL.
BAL.
That's where we instill a small amount of sterile saline into a section of airway and then suction it back out. This collects cells and fluid from the deep airways and air sacs, which can then be analyzed for infection, inflammation, or cancer cells. However, bronchoscopy requires general anesthesia and is usually only done once the patient is stable enough.
Right, you wouldn't want to anesthetize a critically unstable patient. So once a diagnosis, or at least a strong suspicion of the cause is reached, what does treatment typically involve? How do you manage these cases?
Well, appropriate health care almost always means the animal needs to be hospitalized, at least initially, until we can identify the cause and start targeted treatment.
Makes sense.
A crucial first step for pretty much any animal presenting in respiratory distress is to provide supplemental oxygen. And keeping them lying on their chest in sternal recumbency often makes breathing mechanically easier for them while we figure things out and assess their oxygen levels more formally.
Okay, oxygen first.
Then what? Then treatment really depends on the underlying category of disease. For lower airway disease, like asthma or bronchitis, treatment often includes medications to open up the airways, bronchodilators, and oxygen therapy. In cats having a severe asthma attack with bronchoconstriction, we might need to use injectable corticosteroids quickly. For pulmonary parenchymal disease, oxygen is again key. If it's pneumonia, appropriate antibiotics are crucial. If there are underlying blood clotting issues contributing, those need to be addressed. If it's cardiogenic pulmonary edema, fluid in the lungs from heart failure, that's typically treated with diuretics like furosemide to pull fluid off, sometimes along with medications to dilate blood vessels, vasodilators to reduce the heart's workload. Fluid in the lungs from other causes, non-cardiogenic edema, also requires oxygen, careful fluid therapy, and might even need the help of mechanical ventilation, a ventilator, in very severe cases like ARDS.
Okay.
If there's significant air or fluid in the pleural space, we'll need to perform thoracocentesis, that chest tap, to remove it. If it keeps accumulating rapidly, we might need to place a chest tube, which allows for repeated drainage over several days.
It's a chest tube. Okay.
For thoracic wall disease like trauma, surgery might be needed, especially for open chest wounds or severely unstable flail chest segments. If the breathing muscles are paralyzed or extremely fatigued, leading to high carbon dioxide levels, we might need to use positive pressure ventilation to support their breathing until they recover.
Right.
And finally, if the breathing problem is secondary to abdominal distension, we need to address that primary cause, maybe draining ascites fluid or performing emergency surgery to decompress and correct a GDV bloat.
So it's really about treating the specific underlying problem. And what about the important role of nursing care for these critical patients?
Oh, nursing care is absolutely vital. It makes a huge difference. As we said, oxygen delivery is key. We can do that in several ways in a specialized oxygen cage through small tubes placed in the nose, nasal cannulas, using a modified e-collar with plastic wrap to create an oxygen-rich bubble, using a face mask, or even just using the flow-by method, holding an oxygen hose near their nose and mouth.
Okay.
If they need oxygen for more than just a few hours, it's really important to add moisture to it, humidify the oxygen, because dry oxygen can irritate and dry out their airways.
Good point.
Keeping them in that sternal, chest-down position is usually best if they tolerate it. If they can't maintain it themselves, we need to carefully help them change positions regularly to prevent lung collapse in the down lung and skin sores. We also need to monitor their temperature very closely,
Why temperature?
because the increased muscular effort of breathing hard can actually generate a lot of heat, sometimes leading to hypothermia, overheating, and being too hot can increase their oxygen demand and make breathing even harder. It's a vicious cycle. So we need to watch for that and cool them if necessary.
Does their diet play any role in managing breathing difficulties long-term, maybe?
Well, directly in the acute phase, maybe not so much. But if being overweight or obese is identified as a contributing factor, especially for things like tracheal collapse or just general increased effort,
Right.
then a carefully managed weight loss diet would definitely be recommended as part of their long-term management plan once they're stable. Reducing excess weight can significantly lessen the load on their respiratory system.
That makes a lot of sense. And are there any special things vets need to consider if a dyspneic animal needs surgery for some reason? Anesthesia sounds risky.
Yes, anesthesia for these patients requires very careful planning and needs to be tailored specifically to their condition and stability. Making sure we can secure their airway quickly and efficiently is paramount. We often prefer to use injectable anesthetic agents that allow for rapid induction and intubation. We absolutely need to have the capability to provide positive pressure ventilation during the surgery, as their own breathing effort might be insufficient under anesthesia, or we might need to open the chest. Animals with upper airway obstructions can be particularly tricky, as their airways can be very fragile or prone to swelling after manipulation.
So you need to be extra careful.
Extremely careful. It's really important to have a wide range of different sized endotracheal tubes readily available, because you might not be able to pass the size you expect. While surgery, say, to remove obstructing masses in the larynx can be beneficial, it carries risks like postoperative swelling that could worsen obstruction or nerve damage, and also a higher risk of aspiration pneumonia afterwards.
Okay.
We also need to be very cautious using positive pressure ventilation in animals who have a pneumothorax that hasn't been fully drained or sealed, as it could potentially worsen the air leak. Throughout any anesthetic procedure in a dyspneic patient, continuous vigilant monitoring of their oxygenation using pulse oximetry and, ideally, blood gas analysis if possible, and ventilation is absolutely crucial.
And what about medications? I know you touched on some specific ones earlier based on the cause, but is there anything else general to add?
Not really general, no. The medication strategy really hinges entirely on diagnosing the underlying cause of the breathing problems. As we've discussed, it might involve bronchodilators for constricted airways, antibiotics for bacterial infections, diuretics for fluid overload from heart failure, corticosteroids for certain inflammatory or allergic conditions, anticoagulants for PTE, or specific antidotes for toxins. It's all cause dependent. There isn't really a single breathing medication otherwise.
Right, got to fix the root cause. Finally, then, what does follow-up care typically look like for a patient who has been hospitalized for dyspnea and is recovering?
Close monitoring remains essential, even as they improve. We'll be constantly assessing their respiratory rate and effort. As they get better, we'll try gradually weaning them off supplemental oxygen, doing room air trials for short periods to see how well they maintain their oxygen levels on their own. Repeat arterial or venous blood gas analysis and pulse oximetry are important objective tools for tracking their respiratory function and guiding oxygen therapy adjustments. We often need to take repeat chest x-rays, maybe daily or every few days initially, depending on the condition,
Why repeat X-rays?
to monitor the resolution of things like pneumonia, pulmonary edema, pleural effusion, or pneumothorax. We need to see that the lungs are clearing, the fluid or air is resolving, and things are heading in the right direction. It helps guide how long treatment needs to continue.
This has been a really, really thorough deep dive into dyspnea and respiratory distress in dogs and cats.
Thank you.
To sort of wrap things up, what would you say is the most important takeaway message for our listeners from all this information?
I think the key thing to remember is that difficulty breathing, dyspnea, is a really significant sign that something serious is wrong. It's most often indicating a problem within the respiratory system itself, the nose, throat, airways, lungs, or chest cavity. But as we've discussed, it can sometimes be a sign of issues elsewhere in the body, like heart disease, systemic illness, or even abdominal problems. The critical part is that identifying the specific underlying cause through that careful examination by your veterinarian and the appropriate diagnostic tests we talked about is absolutely essential for figuring out the best way to help your pet and giving them the best chance.
And it's become so clear from our conversation today just how incredibly wide that range of potential causes is. It could be anything from, relatively simple obstructions to much more complex body-wide systemic diseases.
Exactly, and that's why being observant of your pet's normal breathing pattern and seeking veterinary attention promptly if you notice any signs of difficulty. Increased effort, rapid breathing, noisy breathing, funny postures is so important. Early detection and intervention can often lead to much better outcomes for many of these conditions.
This has been incredibly informative, truly. Thinking back to that initial concept we discussed, that miscommunication between the brain's demand for breathing and the feedback it receives, triggering that sensation of dyspnea, it really makes you wonder, doesn't it, about all the other subtle ways our bodies and our pets' bodies might be signaling distress or imbalance that we often overlook or don't yet fully understand. Definitely something to think about.
It is indeed. The body's signaling is complex.
Well, thank you so much for walking us through all of that today. And thanks to all of you for joining us for this deep dive.